My name is Mellisa Wheeler, and I'm the Director of Disparities and Outreach at the Levine Cancer Institute in Charlotte, North Carolina. So the Lung Bus is a mobile lung cancer screening project that we began a little over 2 years ago, and we travel across the state of North Carolina screening high-risk, uninsured, or underinsured individuals for lung cancer. So in the last little over 2.5 years, we've screened 470 patients. And actually, the number is a little higher now, but in that 470 patients, we were able to identify 10 lung cancers. We also identified 4 non-lung cancers as well, and we're able to get those patients in for treatment immediately. The patients that we see, about 65% of those are located in rural communities, with the remaining falling in our more metropolitan and urban areas. Now, the average age of our patient falls right about 61, but the pack per year history, the smoking history, is much higher than what is required for screening. Our patients smoke on average about 45.7 pack per year history. With our program, because we're mobile, we've been able to reach a wide, diverse population of folks. So about 25% of our patients that have come through the screening are African American, and the remaining, there's about 3% Hispanic, and the remaining are Caucasian patients. Great question. So access is key, right, to survival and to treatment and to adherence to treatment. We're a safety net hospital system, so we have the commitment to our patients to serve them regardless of their ability to pay. And of course, we try to plug them in where they live, in their local community. If we're unable to find someone willing to care for them there in that local community, then we provide the resource to help them get to where we are for that follow-up treatment. We navigate those patients very closely to make sure that no one is lost to follow-up, and our loss to follow-up rate is less than 4%. You know, there's a lot of controversy about screening, and there are a lot of, especially with lung screening, there's a concern for false positives. Out of the patients that we've screened, we've only had 2 that were worked up, and we identified no cancer. So we really feel very strongly that screening in a targeted high-risk population, which is what we do with the Lung Bus, is really ideal. We find cancer at an early stage, we get folks into treatment quickly, and then we get them back on the road to healing, to work, to contributing to their community. So we feel very strongly that it's worth that effort. Well, our Lung Bus just continues to roll. We are growing. We actually serve probably about 70% of the patients are outside of our normal health system. We're able to go into communities that don't have access to this type of technology. So the ask for us to bring the Lung Bus out is continuing to grow. So we're hoping to grow with that. We are also planning expansion into South Carolina, where we know there is a large proportion of underserved patients. And then we'd like to continue research. This is a population of patients that without our service would ideally never have been screened. So it's a chance for us to really begin to learn what's effective, what kind of resource needs are there. Can we look at screening younger patients? Because in North Carolina, we're known as the tobacco belt, and many of our patients started smoking at 7, 8, and 9 years old. So they meet that threshold way earlier than the recommended age of 55. Anybody that really wants to make big changes in lung cancer, consider a Lung Bus in your own community.